Thank you. Thank you, Ben, and thank you, all of you, for staying after lunch. What I like to concentrate in the next few minutes is clinical research that we focused in the past several months to analyze potential biological markers and clinical biomarkers for establishing a better diagnosis of myelitis and myelopathies. So what you are going to see in the next few minutes is basically a very strict analytical approach to determine which are the factors, clinical, MRI, spinal fluid, and other items of the overall assessment of a patient that may help in the evaluation of myelitis. The data is based in the clinical referral center at Johns Hopkins Transient Myelitis Center. So we base our data in the assessment of all our patients with the diagnosis of transient myelitis that were referred between 2010 and 2015. So we analyzed data from 575 patients that had the initial diagnosis of transient myelitis. And from these 575 patients, we basically filtered and selected 457 patients in which we have a very comprehensive clinical assessment, very well-detailed magnetic resonance imaging analysis, and cerebrospinal fluid analysis. We excluded patients that came already with diagnoses that were established as neuromyelitis optica, multiple sclerosis, or other vascular myelopathies, because those patients already had been diagnosed with other entities different to transient myelitis. And so we restricted our analysis to this group of 457 patients. We focus on assessment of the clinical characteristics, including the demographics, the temporal profile of the evolution of the symptoms. If you remember yesterday, we classified the symptoms based on the time frame of symptom evolution from hyperacute, acute, subacute, chronic. We analyzed the clinical information obtained from the initial neurological assessment, the neurological assessment that was done at the emergency department or the initial clinical encounter. And in addition, we focus on analysis of the profile of the first cerebrospinal fluid, because the first cerebrospinal fluid may be one of the best sources of information to define if there is evidence or not of inflammatory markers. And we focus also on an assessment of the first and second magnetic resonance imaging, and we, in a very well-detailed analysis with the defined localization and topology of the lesions and characteristic of the enhancement in those lesions. And this analysis basically was, number one, focused on the descriptive view of what we observe in the patient population, but particularly the main focus of our analysis was to establish a predictor analysis approach. In other words, based on the data, we like to predict which patients are able to be correctly diagnosed as transient myelitis or diagnosed as vascular myelopathy or diagnosed as spondylotic myelopathy. So we defined some criteria, diagnostic criteria, because it was very important for us to define what was going to describe as myelopathy. And again, myelopathy, as I mentioned yesterday, is a syndrome in which there is involvement of the spinal cord that is producing motor, sensory, or autonomic symptoms. But we define inflammatory myelopathy, those myelopathies in which there was a component of inflammation, either because there was evidence of clear markers of inflammation in the clinical profile, cerebrospinal fluid, or magnetic resonance imaging. We also defined the criteria for vascular myelopathies, and we defined two major groups in vascular myelopathies. The first group was the group of vascular myelopathies associated with ischemic damage of the spinal cord, In other words, either a stroke of the spinal cord that happened in early stages of that myelopathic syndrome. And we define 3 different categories. These are research categories. These are defined not necessarily for clinical management, but these are just for helping us to determine with more precision the value of each diagnosis. So these are research definitions, and in each definition, in vascular myelopathy, we include the exclusion of other etiologies that may be associated with myelopathies, but particularly we pay attention to the distribution of the lesion and the characteristic of the lesions to define that myelopathy. And we define 2 other types of myelopathies, myelopathies associated with strokes and myelopathies associated with arteriovenous malformation and arteriovenous fistula that are abnormalities of blood vessels that happen frequently in people after age 50 that frequently mimic transient myelitis. And that was one of our main purposes, just to make sure that we were able to classify correctly those patients. We also included in our analysis patients with spondylotic myelopathy. Spondylotic myelopathy is basically those myelopathies in which there is a spine damage, bone or discal damage that may produce local changes in the spinal cord that may mimic transient myelitis. And again, this is another frequent mimicker of transient myelitis. And we define other myelopathies, particularly myelopathies that were not associated with inflammatory process or compressive process as spondylotic myelopathy, like other infections, neoplastic processes, metabolic disturbances, or low vitamin B12 or other vitamin problems. This is a long list. I don't want that you pay too much attention to the items, but what I like to tell you is that we define over 80 different items, and these are only few of them in which we included in a predictive model. And from the 457 patients with myelopathy, 247 were diagnosed as inflammatory myelopathy, 62 were diagnosed as ischemic myelopathy or stroke, 30 were diagnosed with arteriovenous malformation or arteriovenous fistula. There is another component of vascular myelopathy, 35 with spondylotic myelopathy, and other 83 patients were diagnosed either with other conditions like vitamin B12 deficiency that mimic myelopathy, or even some infections like Lyme disease-associated myelopathy, another type of myelopathies that were very well defined in terms of etiology because we were able to identify etiological factors. But in all of these patients, we identified the demographics, we identified the past medical history, and we particularly pay a lot of attention to potential risk factors, including infection, including vaccination in the previous 90 days, and including the clinical profile, defining the clinical profile as hyperacute, less of 6 hours, acute between 6 and 48 hours, subacute more than 48 hours to 21 days, and chronic more than 21 days. And we define other set of clinical characteristics as well. We pay a lot of attention to the MRI. We went to the first and second MRI obtained during the initial assessment of this patient. And in each patient, we define the localization of different lesions, the characteristic of enhancement in myelopathies. We are particularly interested in defining if the lesions are associated with patterns of enhancement. But we went and analyzed in each case the topology of the lesion, meaning if the lesion was localized in anterior compartment of the spinal cord, posterior compartment of the spinal cord, lateral compartments, or central cord compartments. And I will explain in detail about this. You can pay attention to this diagram. This is a cross-section of the spinal cord, and this is a diagrammatic representation in which we define the posterior region, the anterior region, the lateral region, and the central cord region. And with the help of the MRI obtained during the first and second assessment, we went and defined level by level the distribution and topology of those lesions, and we defined in each level the cervical, thoracic, and lumbar spinal cord, the localization of those areas of signal intensity abnormalities. And I will show you briefly some of the results that we obtained from data analysis. The first is related with the demographic characteristic of that patient population. And let me go in detail about this. So here we take the group of inflammatory myelopathies and compare those inflammatory myelopathies versus the other groups. On this side, the vascular myelopathy associated with arteriovenous malformation. On this side, the vascular myelopathies associated with ischemia and stroke. On this side, the spondylotic myelopathies, and here, other type of myelopathies. So in this analysis, there was a multifactorial analysis. We tried to determine which of these factors associated with the demographics, with the initial symptomatology, or the neurological exam were able to differentiate well between inflammatory myelopathies versus other myelopathies. In red, you may identify the ones the factors that are actually better differentiating the inflammatory myelopathies versus ischemic myelopathies or arteriovenous malformation or the spondylotic and others. And you can see, for example, that in the group of initial assessment, the presence of a motor symptomatology actually is a very good predictor for establishing difference with other type of myelopathies. In the case of strokes, for example, the presence of a very acute onset of motor symptoms is actually a valuable predictor for defining the potential presence of ischemic myelopathies. In the neurological exam, you can see other factors, and we basically went and analyzed all the items associated with the neurological exam to establish these differences. And I am not going to bother you with the statistical analysis because I'm going to show you a summary of this diagram, but I'd like to pay attention here to the analysis of MRI and cerebrospinal fluid. And this is important because from clinical point of view, in the clinical setting, we use MRIs, and we use a cerebrospinal fluid analysis for establishing some parameters of diagnosis. And we frequently say patients with enhancement of the lesion in the MRI very likely may have an inflammatory myelopathy. But what we found is actually that may be incorrect in some settings because it depends on the time frame of that MRI. For example, if a patient has a stroke, that stroke may be gadolinium enhanced negative during the first 24, 48 hours. But after 4 or 5 days, that stroke may turn to be gadolinium positive. And it would be a mistake for the clinicians to interpret that MRI as a positive inflammatory myelopathy. So that is one of the benefits of establishing this type of analysis and multifactorial analysis. So what we found is that the MRI is very helpful, and particularly when you analyze the presence of enhancement, but it's also very helpful when you introduce other levels of analysis, particularly the location of the lesion, if the lesion is predominantly in the gray matter or if the lesion is predominantly in the white matter. And the same for the spinal fluid. Spinal fluid in our setting is very helpful for defining if there is any evidence or marker of inflammation. And in the analysis of the spinal fluid, we introduce in this multifactorial analysis the white cell count, but we also introduce the presence of oligoclonal bands and IgG index as a potential markers for defining an inflammatory process. And in our hands, we believe that in terms of defining inflammatory myelopathies, once we establish the presence of oligoclonal bands in a patient with a myelopathy, the likelihood of a correct diagnosis of inflammatory myelopathy is high. But the pleocytosis itself is not necessarily a very good marker for defining inflammatory myelopathies. In other words, a patient with vascular myelopathies like a stroke or even arteriovenous malformation may have some degree of white cell presence in the spinal fluid. So the clinician needs to be very, very careful with that type of analysis. This is a heat map. A heat map is basically a representation of the patterns of lesions that we found in MRIs of the patients that are evaluated. Let me guide you on this diagrammatic representation. Again, this is the cross-section of the spinal cord, the posterior region, the anterior region, the lateral, and the central region. So in each patient, we analyze the distribution of lesions, and each of these columns represent the distribution of those lesions. And on this anterior portion, we have the lateral compartment of the spinal cord, then the central cord compartment and the posterior compartment. And each of these levels are the levels of the spinal cord, the cervical region, the thoracic region, the lumbar region. So what we can summarize here is in red is where there is more prevalence of lesions. In this low yellow is the lower presence of lesions. And what you can see here is inflammatory myelopathies have tendency to involve several segments of the spinal cord and several compartments in the spinal cord, including the anterior, posterior, lateral. So what is interesting here is that frequently in patients with inflammatory myelopathies, the central cord compartment and the cervical cord is particularly affected in the overall population. In contrast, if you analyze the patterns that we found in patients with spondylotic myelopathies, most of the patients with spondylotic myelopathies, as predicted, had lesions that were prominently in the cervical spinal cord and predominantly in the cervical cord lesion. And if you take a look of the patient with vascular myelopathies, this is interesting because the analysis and topology of the lesion in vascular myelopathies help in the diagnosis. Most of the patients with strokes, ischemic strokes, had lesion localized in the anterior compartment, particularly in the gray matter. And interestingly, that lesion may be, the pattern of distribution of those lesions is all along the cervical and thoracic spinal cord. However, if you compare this with patients with arteriovenous fistulas and arteriovenous malformation, most of those patients actually have central cord syndromes in which most of the pathology is concentrated in the lower thoracic cord and lumbar cord. Now, what we did was we combined different elements of our analysis, and we pick up the ones that were significant in our descriptive analysis, and we put these in a multinomial and analytical approach to establish which parameter is the best parameter for defining and predicting the presence of an inflammatory myelopathy. And this is the model, or this is the result of the model. If you take the patient with a possible inflammatory myelopathy, and you analyze only the or you take only the factors associated with enhancement in the MRI and pleocytosis, the correct classification rate is only 0.67. In other words, 67% will be correctly diagnosed. But as you can see here, the area under the curve, that is basically our measure to see how good the quality of that prediction is very low. In other words, this number is telling us that our ability to diagnose an inflammatory myelopathy only with the characteristic of lesion enhancement and pleocytosis is not very good, okay? However, in our model of prediction, if you introduce the analysis of the temporal profile, you may improve a little bit the classification rate. But again, the area on the curve is not very good. But if you include the patterns of MRI, the spinal fluid profile, the temporal profile, and you keep adding some of these factors, you are going to improve the quality of the diagnosis. So at the end, if you like to establish a very good diagnosis of inflammatory myelopathy, the clinician need to take in account not only the MRI findings and spinal fluid findings, but need to take in account all of these clinical factors like the temporal profile, the motor examination finding, the localization of lesions in the spinal cord. And if you add all of these together, at the end, you may increase the correct classification rate to 0.87, and the area on the curve is going to be very good. It's going to be close to 0.76. That is much better when you compare with this number that is just what we are doing now in clinical practice. So the conclusion here is the clinician who is evaluating a patient with a myelopathy need to be very careful, and if the clinician use all of these parameters that combine the clinical profile, the motor assessment, and combine some of the elements of the MRI abnormality, the ability to establish a right diagnosis is going to be much better. So I need to acknowledge that this is work from a lot of people, but I like to emphasize that Dr. Barreras, who was actually one of our fellows and partially funded by the TMA, and Dr. Catherine Fitzgerald contributed greatly to the statistical analysis and modeling, because what we observe here is basically a lot of mathematical and statistical modeling that basically allow clinicians to have a better definition of these abnormalities. I'd like to emphasize that many of you, probably some of you have been at the Johns Hopkins Transient Myelitis Center, and probably some of the data from you is included here. And I appreciate very much, and we appreciate very much the contribution that all of you as a patients have for the TMA and for the clinical research projects that we have, because that is allowing us to establish better quality of a clinical care in the future, and the patients in the future don't basically have the nightmares that some of you experienced when you were in emergency departments or clinical settings. And again, the contribution that you are making to the Transient Myelitis Association is making us doing our work, because that is funding the fellows that are working in these research projects, and we really appreciate the contribution that all of you are doing to the TMA. Thank you.